Okay, good morning, everyone. Hello, and welcome to our workshop with Dr. Greg Connolly, pediatrician at Lakeside Pediatrics. I'm Martha Frank, and I'm a family consultant at Vermont Family Network, and I'm your host for today. Thank you for joining us for the COVID-19 Pandemic and Your Family workshop. All of our workshops, including previous ones, are recorded and can be watched on the VFN YouTube channel. The link is on our website, which is vermontfamilynetwork.org. Everyone who registered for today's workshop will receive a follow-up email with a link to the recording. Vermont Family Network, next slide, thank you. Vermont's Family Network has families of children with special health needs and disabilities and professionals who serve them for more than 30 years. We are the federally designated Parent Information and Training Center, to Family Information Center, and the Vermont chapter of both Family Voices and Parent USA. Today's workshop is being recorded, so please keep in mind about sharing as you share information about your situation. If you're comfortable, we encourage you to turn on your camera. Only the people who speak will end up on the final recording. If everyone can please mute themselves, unless you're speaking, that would be really very helpful. You can ask questions out loud or you can use the chat. I will say if we have technical difficulties and you can't use the unmute button, just please rely on the chat and we'll make sure that we get your questions out there. Let's see, you can feel free to share any information or links in the chat on the bottom of your screen. Feel free to find resources and post them that you found particularly helpful. We know that you can learn a lot from each other. Parents always do. I'm excited now. It is my great pleasure and honor to introduce Dr. Greg Connolly. Thank you, Greg. Thank you for joining us.
Thank you, and thank you for inviting me to do this. I'm honored to be invited to give this presentation today. All right, so this is intended to be an interactive session, and I hope that I can answer your questions as they come up. If you would like to ask questions, please feel free to unmute yourself and interrupt me and ask your question, or enter your question into the chat box, and I'll try to address your questions as they come up. Next slide, please. As Martha said, that I am a pediatrician at Lakeside Pediatrics in Burlington, and I think the reason I got asked to do this was because I've been doing, every Thursday, I've been doing a weekly COVID-19 update on our Lakeside Pediatrics Facebook site. And the other reason I think I got asked to do this is because Martha is my aunt, and I have a lot of connection with the Vermont Family Network, both professionally and personally. Mart is my aunt and has been working there for years. Kay Van Wart is my mother-in-law, and Kay worked at VFN for many years. And the Vermont Family Network has been very helpful to my own family. We also have a child with some special needs, and Vicki Crocker has been helpful to us in having meetings with the school. So, as is customary for any kind of presentation like this, I do need to make my disclosures known to you. I don't have any relationship to the pandemic except that it tried to bankrupt me. Just kidding. We're all doing great over here. And I don't have any relationships with the vaccine or drug manufacturers. Too bad. Next slide. Thank you, Rachel. So I want this recording, or sorry, this presentation to be directed toward your goals. This is a massive topic, COVID-19, and my challenge is going to be to narrow it down to things that are most meaningful to you. So if you have goals for this presentation, please feel free to enter them into the chat box or interrupt me and tell me what you'd like to learn. I'm guessing that the things that you'd like to learn are just having a deeper understanding of the science of COVID-19. I find that fascinating, and I think that we get a surface skim understanding of COVID by looking at the news. But I find that the science a little bit, deeper science more interesting to look at. I want you to feel supported, and I want you to feel hopeful. So those are my goals. and let me know what yours are. Next slide, please. I'm going to start by going into the science of it. Yes, I probably will dig myself into a hole with all the basic science stuff. Then I'm going to talk about the latest updates, the numbers, what's happening where, especially the mental health impact. I know that our families have all been struggling a bit with the mental health impact. And then I'll talk about the reasons for hope. Next slide. All right, so starting at the beginning, I'm going to make this kind of a quick overview because you've all heard it. The World Health Organization, which the Trump administration had dismissed as not being helpful, is now back in the situation with America, and they have been in China for the past 2 weeks investigating the beginnings of the pandemic. And their two main conclusions are, one, that the Wuhan Virology Institute was almost certainly not the source of this pandemic, as the Trump administration leaked and espoused that theory. Probably it was a viral transmission from an animal, most likely a bat, to humans. And the first cases were reported in Wuhan, China. That's not to say that they definitely started there. To their great credit, those doctors and scientists recognized the pandemic and infection getting out of control, and they reported it to the world. China, the central government in China has gone to great lengths to kind of quiet the rhetoric and the data coming out of the pandemic from China. But the other side of that is the Chinese government has done an excellent job of controlling the pandemic. There are reports of cases in France that were before December 23rd of 2019, and also questions of whether there were people in Italy who had the virus before then too. Next slide, please. Okay, this is where I get lost, and I think I lose you guys at hello. I wanted to go through some of the basic science of this. Ignore this for right now. Try to imagine you're in a room and you're in with other people, and as people are breathing, out come droplets of moisture. In those droplets is contained virus, and the virus is within the big droplets as well as the tiny microscopic droplets. So it's both spread by droplet, which those are the bigger droplets that are heavier and tend to fall out of the air and land on the ground within 6 feet of a person. And the aerosolized particles can float around in the room for a while. So this is where the 6-foot distancing thing came into play, thinking that, oh, it's mostly droplet spread, and if you can keep 6 feet away from each other, you're safer. That is true, but it's also about how long you're in an enclosed space with somebody because of the aerosol spread. The other way it can spread is on infected objects. This is not a primary source of spread, but it is why people are very careful washing their hands and going to the grocery store, wearing a mask, washing your hands. So when the virus comes into the body, it usually gets in through the nose or the mouth or the eyes. And if it goes in through the nose or mouth, it'll get into the lungs. And in the lungs, the virus will. So this is now where we're coming into the diagram. This below this line is the inside of a cell. This would be the cell wall here. And this cell, let's assume, is an epithelial cell in the lining of your lungs, which is in the alveoli, so the air sacs in your lungs. And the virus comes along. It has these spike proteins around its surface, which are sticky kind of landing pad proteins. And the landing pad or the receptors are the ACE2, as an angiotensin converting enzyme 2 receptor. They catch a hold of this spike protein, and the spike protein gets caught and it starts to translocate across the cell membrane. It opens up the virus membrane and lets out the RNA, ribonucleic acid, which is the genetic material of this virus. It's an RNA virus, not a DNA virus. There's two types. The viral RNA, the genetic material comes in, and then this is the RNA strip here. The ribosomes, it uses this cell's own machinery to make its copies of itself. So the ribosomes that normally are making this cell's genetic material and making copies of this cell, they're hijacked, and you get translation of the viral RNA into proteins. So it goes down here. Well, I don't know, you don't need to necessarily follow this, but the message is the RNA translates into proteins that then go from this endoplasmic reticulum up into the Golgi apparatus, and the proteins assemble along a membrane, and the membrane kind of involutes or into a round cellular structure, and then leaves many copies of the virus are made out of one cell here, and then this cell dies. So these viral particles then go on to infect other cells. They get into the bloodstream, and they wreak havoc from there. This cell would typically die as these viruses leaving now a dead epithelial lining in the lungs. And if the epithelial lining is compromised, then other germs like bacteria can come in and wreak havoc. So that's a bacterial superinfection, we call that. So that is why around 10 days out from an infection, you're at such high risk, because you're highly, you're prone to a serious bacterial infection at that point. The primary way that this virus causes trouble in human beings is not the damage that it does itself, but the way that it triggers the immune system. It elicits a very exaggerated immune response, and as the immune system excretes cytokines, so chemicals such as interleukin and tumor necrosis factor alpha, chemicals that cause inflammation and swelling, that inflammatory state can lead to blood clots in the blood, and so the blood clots can then go and close off an artery and arteriole and cause death of those tissues, so like a stroke or a heart attack, things like that. And the other thing it will do is, because there's so much inflammation, it'll make the blood vessels dilate and get leaky, so you lose blood pressure. And you can go into shock, which means that you don't have enough blood pressure to bring oxygen to your tissues, and your tissues start to die. So Rachel put in the chat box that we're having technical issues. I hope that those technical issues are just listening to me babble on about scientific stuff. Is there anything that I can do to help, Rachel? I'm going to charge on, hoping that things are getting better. Next slide, please. Guys, that's the worst of it. After this is going to be more stuff that's more relevant to you all. So we talked about this. All right, move next slide, please. Okay, so not only do people suffer from the acute infection, but 1/3 of people who get infected with COVID then go on to have what we call long COVID. So this is a prolonged syndrome characterized typically by a sense of brain fog, fatigue, trouble with your breathing, so respiratory issues, joint pain, muscle aches. So it's not one and done. For 1/3 of people, it lasts a long time. Okay, next slide, please. All right. I'm sorry about the graphic photo. That's a sad photo. This is a rash from MIS-C, M-I-S-C. You've probably heard of this in the media. This is multi-system inflammatory syndrome in children, very similar to an entity that we know of in pediatrics called Kawasaki disease. Essentially what happens is these kids have 10 days to 2 weeks out from their acute infection, their immune system goes haywire, and they have full system. Everything gets inflamed and swollen, and blood vessels dilate, and then they get these red blotches on their skin. They get low blood pressure and go into shock, and it's a pretty nasty thing, and it has a fairly high mortality rate. I'll talk a bit more about MIS-C when I can find my notes and give you some real numbers. So where are we at here? Okay, here we go. So, okay, 1,659 kids in the US have had this MIS-C, and 26 have died. So that's a good proportion of the number of kids who are dying from COVID. The better news about kids is most of the time the kids are asymptomatic. We probably dramatically underestimate the number of infections in children because they don't present with anything. For some reason, it is that kids don't seem to get terribly sick with COVID compared to adults. Newer research came out this morning that it doesn't seem to be that kids have more recently had a lot of coronavirus colds from being in school that then offers them protection against COVID-19. So it's not really known why they get less sick than adults. But they do transmit it to others. It's important to know, I know a lot of you have concerns about sending your kids to school. The Center for Disease Control and other organizations are feeling as though, and the American Academy of Pediatrics are feeling as though school is safe for kids to attend. There was a research project, a study done in Wisconsin, where they found that the rate of infection being in the school was less than the rate of infection being out in the community. That supported, along with other research, I think South Carolina and Mississippi had some projects too that supported the CDC's recommendation to have schools be open to kids. That, of course, is different if your child has special needs, and we'll get more into that in a bit. Actually, let's talk about that now, because I think that's on your minds. The questions that I've had prior to this this presentation from you all, and questions that I get from parents often in my practice are about the specific risk of their children who have special needs in relationship to COVID-19. Also, questions about whether school is safe. And these are tough ones to answer because, to be honest, there is really not data for me to cite about specific illnesses except for Down syndrome. A study out of Oxford, England, of 8 million adults, so it's a big study, found that individuals who have Down syndrome are 5 times more likely to be hospitalized with COVID and 10 times more likely to die of COVID. The reason is multiple reasons. That the immune system in Down syndrome is a little compromised at baseline. And so their immune reactions may be more intense, and their body is less able to handle the immune reaction to a COVID infection. Moreover, 50% of children with Down syndrome are born with congenital heart defects. A lot of kids with Down syndrome have pulmonary issues such as asthma, and they tend to be hypotonic, meaning their muscle tone tends to be low, so it puts them at higher risk. Certainly, other special needs are an increased risk. Children with cystic fibrosis, of course, are at increased risk, and they are considered high risk if they have poor pulmonary function based upon their pulmonary function testing. Kids with severe or moderate to severe asthma are at higher risk. Kids with neuromuscular disorders such as muscular dystrophy, because they have a harder time expanding their lungs when they're breathing, are at higher risk of a severe COVID infection. Kids who have indwelling catheters or medical equipment implanted, or ventricular peritoneal shunts, are at higher risk. Kids who have diabetes, are higher risk, not only because their immune system may be a little bit compromised, but also because when they do get any infection, their sugars tend to go haywire, and it's hard for them to recover. There are plenty of other things that I could cite, other conditions. I guess the main point is it's a lot of this is the art of medicine and not the science of medicine, trying to figure out what an individual's risk is and what families and caretakers are comfortable with in terms of how to isolate and how to expose their kids. I would encourage you to talk to your pediatrician about this. Who do you let in? Do you let home services come in and help with your kid? Do you continue to have the PCA come into your house? What kind of services can the school provide? Can they be provided in a safe space? I have one kid with chronic respiratory insufficiency after she was born prematurely and was on a ventilator, and she has cerebral palsy as well. And the school made a tremendous compromise and continued to offer this kid all of her school-based services, PT and OT, in the cafeteria at an off hour, so that it was a big wide open space and there were no other kids around. And then that kid did homeschooling for the rest of the time. I have another kid whose family has decided to, this kid is dramatically immunocompromised, and the family decided to, kind of isolate and quarantine, and they've had nobody come in their house at all. They've not left their house. They've lost jobs, and it's very hard for them, for their mental health, for their financial health. And this child is not getting the educational services or the physical education or physical therapy and occupational therapy and speech services that she would have gotten otherwise, but they're keeping her safe. Your pediatrician ought to be able to help you figure out what is safe and what's not safe. And I would not be surprised if your pediatrician and your specialists or even two pediatricians in the same practice had different ideas about what is safe and what's not, because again, a lot of this is the art of medicine, not the science. And it's, some of it's a guessing game, and it's based upon what kind of level of risk that we think we are getting a family into. And talk to your schools. These teachers, I want to applaud the teachers and paraeducators for the tremendous work that they've been doing. They're way overburdened by this remote learning, hybrid learning system, and they're doing a wonderful thing. Okay. So that's the kids with special needs. Let's see, what else do I have here? Let's talk about, can we do the next slide, please? I think the next slide was going to be about mental health. Well, maybe I skipped a slide on mental health, but let's talk about it. So, mental health is really a primary part of this pandemic, as many people are suffering. Most of my job has gone from sick visits and well checks to now some well checks, but mostly mental health checks, which, I'm happy to do. But kids are suffering, they feel isolated, they're shut in their rooms. The only way they can socialize with friends is sometimes through video games. And it's really obviously very, very hard. Also very hard for families, especially families with kids with special needs. Everyone's family is different, and nobody can really understand what it's like for a family when a kid with special needs loses their routine, loses their services, and it all comes down on the primary caretakers, the parents generally. when you get your kid into a good groove, it's really rough on them sometimes, depending on their disability, to then throw everything into chaos. So parents need help, kids need help. Probably the best thing parents can do for their kids is to maintain their own mental wellness, which is obviously very hard to do. But if you can, try to figure out ways to get exercise, maybe meditate, maybe you get counseling yourself if you can find it, and work on your own mental wellness, and then just provide stability for your kid. How do you talk to your kids about COVID? I think kids need the black and white. They don't need to hear your worries about all the gray areas. They just need to hear, this is what we know. You're safe, we're safe. We're gonna do everything we can to keep them safe. That's what they need. They need that. They need a lot of empathy. They need you to listen to them, absorb their worries, absorb their feelings. Don't reflect back your ideas and your opinions. Just hear how they're feeling, and let them get it out. Don't try to solve it for them all the time. And don't force your kids to talk about it. It's not going to go well generally if you decide that tonight at 6 p.m. we're going to have our talk about COVID. It certainly is good to try, but let them come to you, let them open the door a little bit, and then that's when you sneak in and you go. All right. Okay, now we're talking about reasons for hope. The numbers are dropping. I have a slide in there somewhere that you don't need to jump into it yet, but the past 3 days in the US, we've had fewer than 100,000 new cases per day, which still is a tremendous number, but those are the best numbers since, I think, early November. And I think what's happened, pretty clearly what's happened, is that after Halloween, we had a bump in cases. After Thanksgiving, we had a bump in cases. And then after the Christmas, Hanukkah holidays, New Year's, we had a major spike and peak. Hopefully that's the tallest peak we get to, but we were having over 4,000 deaths per day. So now that peak has come down, and that's really hopeful. I don't think that the peak is coming down because of vaccines alone. I think it's because of continued work on masking and social distancing, and certainly the vaccines help, as 9% of Americans have now had one dose of a vaccine. But I also think that time has passed since the holiday gatherings. I certainly hope that the Super Bowl did not lead to a lot of gatherings, and we don't have another spike in 2 weeks. Okay, we've got some central leadership. So this is where I try not to put my foot in my mouth. So Marta, if I make any political statements that are maybe unfavorable, maybe hit the gong and I'll know when to stop. But why is it that America is by far in the worst shape of any country in the world when we have the most money and the most resources? It's got to do with central leadership or lack thereof. We had a leader who didn't believe the pandemic is real, generally doesn't feel that science is real or worth funding or worth supporting, made masking a political, an unpatriotic act to wear your mask, would host fundraisers and parties where nobody was wearing masks, then everyone got sick. And there was no central leadership. The COVID task force that was set up was ignored and almost disbanded. Even prior to the pandemic, this president shut down President Obama's pandemic preparedness division. And so when it's left all up to state governors to figure out what to do, but they all do their best, but without some central leadership, it's hard to make a good unified response. The other reasons we're not doing well is Americans have been the wealthiest, most entitled group of people in the world for many years now, and we're a bit entitled and a bit selfish, and it's hard for us to have group thinking as opposed to just selfish thinking. So there's a lot of people who are doing all the right stuff And I applaud them for masking and distancing and not visiting family, making those sacrifices. And it's very unfair that a smaller proportion of people are ignoring all those things and making our lives harder and causing so many more deaths and sicknesses. If we had shut down this country for 4 weeks at the beginning, this pandemic would have been over. I didn't hear a gong. Was that a gong or a little bell? Because someone
No gong, but we do have a question, Greg.
Okay.
Richardson, we have a question. Do you have any idea how people with disabilities will be prioritized for the vaccine, and how about their parents?
Okay, let's jump to vaccines. We'll get back to treatments if we feel like it, based on time. Valerie, thank you for your question. And I know this is at forefront on everyone's minds. This has been left up to states. The Center for Disease Control nationally has made their recommendations on who gets priority for vaccines, and Vermont has largely followed those recommendations. The recommendations are based upon who is most likely to die from COVID. And right now, the highest risk is really based upon age stratification. So the 30% of the deaths from COVID have been in people who have been living in nursing homes and long-term care facilities. So the elderly and people in nursing homes are certainly highest risk and get the first priority. Here in Vermont, we're right now in the 75 and older age group. The group 1A was the healthcare frontline workers and nursing home staff and residents. Next, in a few weeks, hopefully we'll switch to the 70 and above group. After that is the 65 and above age group. And then after 65 and above comes kids and adults with special needs and high risk conditions. It is not clear to me yet exactly how that gets governed. If your family is able to call the health department and say, I have a person in my household with a high risk condition, can we come and get the vaccine? Or if you'll need a note from your doctor. But I think that's a work in progress, and we'll know more about that in about a month. So I'm hoping that by mid to late spring, there will be vaccines available for kids with special needs. Now, kids, I say, is relative because neither the Pfizer nor the Moderna vaccine is approved for children under age 16. So we're talking mostly about late teenage years and young adults who might get the vaccine. So this brings up another issue. Yeah.
All right. I'm sorry. We have another question. Annie Hone. What is the latest science on how well the vaccine blocks transmission? We have been without the services of our PCA since last March due to my son's severe susceptibility to severe complications, respiratory viruses. Our PCA is about to get their second COVID shot this week. I'm glad they will be protected from severe illnesses and death due to COVID, but we are still not sure if it means they still can't get infected and transmit it to my son or someone in my household. So I think this is a good question. People wonder if someone's been vaccinated, can they still transmit it to other folks?
Yeah, and it brings up a couple other questions as well. Thank you, Annie. First of all, I'd like to address the fact that PCAs are getting their vaccines, and even if your PCA is with your child 1 hour a week, they are going to get a vaccine, whereas the primary caretakers, mostly parents, are not generally eligible for vaccine unless they are of a certain age that qualifies them. And that's clearly not the safest thing for your kids. In response to that, I've written a letter, and everyone in my practice has signed it, and we've sent this letter to the Commissioner of Health. We sent it yesterday, advocating for caretakers of children with special needs and children 16 and older with special needs to be given the vaccine at an earlier prioritization based upon their doctor's recommendation. So I don't know if that's going to go anywhere. I doubt that it will, but at least we're trying. The PCA, the second part of this question is how easy is it, can they transmit the virus still after they get the vaccination? The data is not there yet. If this vaccine, or if these vaccines, the Moderna and Pfizer, work like other vaccines that we typically use, like measles, mumps, rubella, other vaccines, then it would be typical that a person that after vaccination would not transmit that infection to other people. So we would certainly hope that that's the case. There is one bit of data from the Astrazeneca vaccine, which is due to be approved in the US, I think in March or April. And that's the one out of Oxford, England. And they found that there was a 67% reduction in the spread of the virus from people who had the vaccine compared to people who did not have the vaccine and got infected with COVID. So some evidence that you don't spread it as much. However, that does leave 1/3 of the people still were able to transmit the virus to other people. So the way a vaccine works is it gives you your immune system generates antibodies. You generate antibodies against the infection. It doesn't mean the infection can't, get in your nose and your mouth and get into your body. It just means that you probably won't feel it because your antibodies will fight it off before you know you have a problem. So you certainly can have COVID or coronavirus in your nose or in your respiratory tract and cough and spread to somebody. It's just that your viral load will be much lower because the virus won't have the chance to replicate much in your body. So technically, yes, somebody who has been vaccinated can still pass on the virus. The other thing to think about is that we now have variants of coronavirus that are becoming prevalent in the US, and it's not clear whether the Pfizer and Moderna vaccines are working for these variants or not. A small study in South Africa of the Astrazeneca vaccine, this is only 2,000 patients, so it's not many patients, wasn't a great study, but it was the best they could pull together on the ground. Found that, with 1,000 patients who got the vaccine, the Astrazeneca vaccine, and 1,000 patients who got placebo, there was only a 10% reduction in getting COVID, the South African variant of COVID there, which the government of South Africa felt was not adequate. So they canceled their order of AstraZeneca and are going to go with another vaccine, I think Novavax, because Novavax has found some data that their vaccine might be more effective against the South African variant. Now, the important thing to talk about with that data also is that they didn't look at moderate to severe disease or death outcomes, because so far, the real amazing thing with these vaccines is that all of them so far have 100% efficacy at preventing severe illness and death. That is just shocking. Absolutely amazing. So, so that's hopeful news. I've really strayed far from Annie's question here, but I think the point is, okay, I'm coming back.
And she appreciates your advocacy, Dr. Connolly.
Thank you, thank you. I think the point to Annie is, the variants, especially the British variant, are spreading in the US, and the British variant, the doubling time of that virus is 10 days, meaning that every 10 days, the amount of people who are infected with the British variant is twice what it was before. And it's predicted that by the end of March, most of the COVID in the US will be the British variant. So far, Pfizer and Moderna think that the vaccine does work against the British variant, but that's not based on any data that I've seen. Just as an FYI, AstraZeneca is working on a new vaccine that's altered to address the South African variant. So these pharmaceuticals are adjusting, and I know Moderna was working on another vaccine variant that would work on some of these variants of the virus coming in. I got into vaccines there. I think, yeah, we're going to keep going, I guess, with vaccines. I've talked about the specific vaccines let's go through some of them. I've mentioned Pfizer and Moderna. Both of those are 95% effective at preventing mild to moderate COVID infection, and actually just COVID infection in general. 95% efficacy is crazy good, and they're 100% effective at preventing severe illness and death. These are both mRNA vaccines. So RNA is, again, that genetic material. They have RNA synthesized that encodes for the coronavirus's spike proteins. So they are able to inject the mRNA into the body, and it gets into the host's cells, and then uses the host cellular machinery to crank out spike protein. So then your body gets produces a whole lot of coronavirus spike protein. So this is not something that can cause illness for you. And your antibodies recognize the spike protein as something foreign and make antibodies to it so that you get immunity. Similar to that is the Astrazeneca vaccine out of Oxford University in England. This is a DNA model, not RNA, and they use an inactivated adenovirus as the vector. So they inject this coronavirus DNA into an adenovirus that's not going to make you sick, and the immune system recognizes an adenovirus and attacks it, and get the DNA from inside there, gets into the host cell, and then uses the host cell machinery to crank out spike protein from coronavirus, and then you generate antibodies. Both of those technologies are new for vaccines. Both of them are shockingly awesome. And they're not new for research techniques. They've been used in science labs for a while now, but it's generating a lot of concern from patients and people around the world because it's new and people don't trust it. It certainly is not going to be permanently incorporating the RNA or DNA into your genome, your genetic material, as these DNA and RNA strands are fragile and they break up after a certain amount of time. And certainly the government is not injecting a tracking chip into your body. I think I don't need to go through all the other vaccines. There are 67 vaccines being developed right now, and a bunch of them are in clinical trials, and 6 vaccines are approved and being used around the world. So that's shocking. In less than a year, we have 6 vaccines that are all highly effective. And then the question is, how effective will they remain as these variants of the virus propagate? But we will adjust. I want to talk a bit about inequity. The US has ordered enough vaccine to cover its population 4 times over. Canada has ordered enough vaccine to cover its population 6 times over. How much you've ordered doesn't mean how much you've got to deal with, or how much a deal that the pharmaceutical has agreed to give you, nor does it mean how many that you will have delivered to you. But it's just a bit insane to me. And meanwhile, poor countries around the world are getting none. Bill Gates and the World Health Organization are working on this. They're trying to secure 1 billion doses for poor countries. And there's an organization out of New York City called COVAX that aims to give 336 million doses to underserved areas in the world by this summer. The country that's contributing most to COVAX is China. They've done a lot to work on their PR and to help with this pandemic. China has 2 vaccines that they developed and are producing and using. They're Sinovac and Sinopharm, and they are effective, although the Sinovac and the Brazilian study, they found it to be only 50% effective at preventing COVID illness, although I'm not sure about how much it prevents death. The vaccine rollout has been heavily criticized. We need to remember that this is the largest public health movement ever undertaken. and it's been very impressive, actually. But the Biden administration is working hard on ramping it up. And in fact, we've seen the number of shots increase to now, whereas it was 0.9 million shots per day at the end of Trump's term. Now it's 1.5 million shots given per day in the US. Now 9.9, almost 10% of Americans have had one dose of the vaccine, and 3% are fully immunized with 2 doses. So there's a lot of inequity here amongst who's getting the vaccine. People who have money, more than $90,000 annual income, are twice as likely to have gotten a vaccine or know somebody who's gotten a vaccine than people whose income is less than $40,000 a year. And in New York City, 46% of the people who got a vaccine dose were white, 16% Latino, 16% Asian, 12 Black. Those percentages do not reflect the percentages of those populations in New York City. Clearly, there is some preference given somehow to people who are Caucasian. And the Biden administration, I think, is doing the right thing, releasing all the government's doses of vaccine. However, we will run out eventually here. But the Johnson & Johnson vaccine, which is a 1-dose vaccine that doesn't require a freezer, that one should be approved by April, and the Astrazeneca vaccine also should be approved by April, and we have deals with those companies to provide millions of doses. So that's good. And here in Vermont, we're amongst the best at delivering vaccine. We've given out enough vaccine so that over 9.8%, I think we're in the 10 somethings now, percent have gotten one vaccine. So we talked about some of that stuff. Oh, hesitation, vaccine hesitancy is a big deal. The Kaiser Family Foundation has been doing a lot of tracking of vaccine hesitancy, and right now in the US in January, I know it's February now, but the percentage of people who were planning on waiting and seeing how the vaccine worked before they got a vaccine is 31% in America. 7% said they'd only get it if they had to, if they were required, and 13% said they would definitely not get it. That is 51% of our American population hesitant about getting the vaccine, which is better than the polling from December, which was more like 60% were hesitant. The hesitancy is higher in people of African American heritage, as only 49% of Black adults said that they would get a COVID vaccination. This is in light of a long history of unethical medical research conducted on Black populations. So just to mention about kids getting vaccines, there is one way you could get your kid a vaccine potentially early, and that would just be through joining one of the trials, you know, AstraZeneca's or Moderna's. Pfizer's already fully signed up. Okay, so that's vaccines. The Sputnik vaccine out of Russia was found to be 91.6% effective at preventing COVID and 100% effective at preventing disease and death. That one, it was interesting to me because when it came out and was approved before anyone's vaccine was, I think there was a lot of chuckling that they had only done very small studies before releasing the vaccine, and lo and behold, it's one of the most effective vaccines ever created. The vaccines themselves aren't going to stop this pandemic. Certainly, it's not going to do it at the rate that the pandemic is spreading in America. So we have to beat this thing in the old-fashioned way. Still, masking and social distancing are the hallmarks of preventing infection. Masking is important. A typical cloth mask may only be 26% effective at preventing you from getting COVID. So double masking is actually a good idea, a surgical mask and a cloth mask over the top. N95 masks are the best masks that there are, And the Biden administration has invoked the Wartime Production Act to get more of those manufactured and get distributed. Even in my practice, it took us months to get N95s. And N95 is 90, the 95 refers to 95% of particles get trapped in N95 masks. And a researcher in Harvard, Dr. Abrar Karan, estimated that if everybody in America wore N95s consistently for 4 weeks, the pandemic would be finished. Other stuff that's coming up in Vermont, we're going to start doing genotyping next week on some of our swabs, our COVID samples. Genotyping is when you identify the exact gene map of the virus that you detected. And that's how you figure out if the infection is from the typical coronavirus virus that's been circling in the US or from one of the new variants. And that's going to be very important because around the country, we're going to be doing more and more genotyping. And if we can figure out where the variants are, then we can do intensive quarantining and shutting down of those communities so that it doesn't spread.
Dr. Connolly, I just want to let you know we've got about 10 minutes left.
Okay, good. Thank you. It's important because the variants may be more virulent, meaning that they spread easier. The British variant spreads 50% more easily than the typical coronavirus that we have circulating in America, which means that every activity that you do, every time you go to the grocery store, your risk of getting an infection from that variant is 50% higher. And it also is 35% more deadly. We think, based on newer research. There are some treatments out there. I think only 3 really are somewhat effective. The most effective one being old school steroids. Dexamethasone reduces death by 1/3 in patients with severe COVID. Steroids decrease inflammation in the body. And if you can tamp down that immune system's hyperreactivity, you're going to have fewer complications. Similarly, there's an antiviral called remdesivir. Remdesivir is one of the ones that Trump, I think, was given. This one is only modestly effective, and it was studied in people who had severe COVID and were in the intensive care units. The data that supports its use is that it decreased the recovery time of hospitalized COVID-19 patients from 15 days to 11 days. So that's not a whole lot of difference, but at least it's something. The more promising data is coming out with monoclonal antibody drugs. There are 3 out there. I only have 2 listed in my notes, but there was bamlanivimab. It's a cocktail of antibodies to COVID proteins that they inject into the body. This company did a study of about 1,000 nursing home patients. And what they did was when a nursing home reported a case, they rushed into the nursing home. Everybody either got a placebo or this antibody cocktail. And those who got the cocktail had a reduced risk of hospitalization by 72%. And Regeneron has a similar antibody cocktail, and they have decreased doctors in hospital admission by 57%. So there are some positive things out there. So I think I've covered a lot of stuff. I want to make sure I got back to things that. Oh, we could go through the slides. What's the next slide? I had my wife up on the screen for like an hour. That was my wife getting her second shot from one of the pediatric critical care transport team nurses. This is the map of the coronavirus case count out of the New York Times. It's come down quite a bit, and it's gone down even further the past few days. Next slide, please. Next slide, we've already talked about enough politics. I talked about the treatments, so we can do next slide. That's my son giving me a flu shot. He didn't actually have a needle on there. It was more of a joke. Next slide. This is one of my most beloved kids. That's Addie, and she has severe immunocompromise, and she is one of the examples I discussed earlier. So we've talked about that stuff. Let's switch on to the next slide, please. We talked about the variants. Next slide. And this stuff. Sorry, I could have done this earlier, but I just got into my talking mode. I just kept going. Okay, next slide. Okay, yeah, this is where I make predictions. Should be good. I think that this is going to be around for years. And I think that we're going to get some, eventually some herd immunity, but I think that like other viruses, like the flu virus, it will continue to morph and get into us and get us in different ways. But we have this tremendous response from science that is just amazing, and the vaccines are unbelievable. And they're changing the vaccines to change the variants that are spreading. So I am hopeful that at least now I feel like there may be some light at the end of the tunnel. I have to be honest, in early January, I felt like I didn't see any light at the end of the tunnel. It was looking bleak, but I think we're on a good stretch now. That's one of my kids there, Andrew. All right, so yeah, get your vaccine when it comes out available. Next slide, please. These are some of the sources. I didn't put formal citations, but there are a lot of other sources as well. The F.A.A.P amongst them I didn't put in there. Next slide, please. And that's my family out on a hike on Rock Point. We took our masks off for a photo. So.
Great picture, Dr. Connolly.
Well, thanks. And my wife is a pediatrician as well. She's at Timberlane Pediatrics in Milton. So.
Dr. Connolly, we'd like to really thank you for today's excellent workshop. Everyone here, if you want any more information, Dr. Connolly hosts these on Thursdays, so you're certainly welcome to tune in on Thursdays. He posts it on their Facebook page, and it's an opportunity for people to ask live questions and get new information. So for today, I'd like to also tell everyone that there's going to be a link to an evaluation in our chat. Please take a few minutes to fill that out so we can make improvements and fulfill our grant requirements. Everyone who registered for today's workshop will receive an email with the link of the recording and a PDF of the presentation. Please take a few minutes to fill out the survey so we can make improvements and work on things that we can do to help these in the future. We do have lots of other workshops coming up, and you can find the details of that on our homepage of our website, which is vermontfamilynetwork.org, along with the links of previously recorded ones. Please save the date for our annual VFN Conference. It's on April 8th and 9th. It's 2 days. And our theme is Imagine, Inspire, and Innovate. We're really excited to have two internationally known presenters joining us, and the registration is going to be posted pretty soon. We've got lots of information on our website, and getting connected is really easy. You can follow up on Facebook, or parents can join our closed Facebook page, lots of that. And the name of our closed Facebook page is Vermont Families of Children with Special Healthcare Needs. You can also sign up for a monthly e-newsletter and check out our YouTube channel. We have lots of great presentations that have been recorded in the past. So, please look on our website for upcoming workshops. I know right off the top, next week, I'll be moderating what's called dual enrollment with Jesse DeCarolis from the Agency of Education. Dual enrollment is really trying to see more youth with disabilities participating in to change the trajectory of where their futures go. So again, everyone, thank you so much, Dr. Connolly. Thank you. So appreciate having you come and join us today and being so very available to the families that we work with.
Thank you. I was honored to be asked. Thank you.
I'm getting a lot of in the chat box, Dr. Connolly.
Thank you.